So if a woman goes in, she has a suspicious finding on mammogram, it's considered, highly suspicious. So the next recommendation is biopsy. And I know you have very strong opinions about how that biopsy is done and who does the biopsy. So can you kind of explain what you would like to have happen at that point and how our viewers as clinicians can help women make sure that that is followed?
Got it. So ideally, I prefer that a woman is examined by a breast surgeon or someone specializing in breast disease prior to the biopsy, and this is for several reasons. Number one, I perform biopsies myself, and so when I see someone that I know has a high clinical suspicion of cancer, I'm already planning in my head that person's definitive surgical procedure. So where I choose to put my nick in the skin for my minimally invasive biopsy is already planned out. It's already well thought out. I also can then assess whether the lymph nodes, the lymph nodes under the axilla, are clinically suspicious based on an ultrasound that I would do, and also based on a physical exam. And that's very important because we base our clinical staging is incredibly important for our definitive treatment. Patients that have clinically positive nodes before chemotherapy, those are patients that even if they have a mastectomy, they're likely to get radiation therapy afterwards. So it's a very important factor, and once someone has a biopsy, those lymph nodes 6 or 7 days later are going to be enlarged. They're going to be inflamed because they're doing what they were meant to do. So even if a surgeon doesn't do their own biopsies, I think the patient should see the surgeon first, and then if the surgeon sends the patient back to a radiologist, they can discuss incision planning, and that way the patient has a relationship with someone when they get the diagnosis of cancer.